Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami with our weekly Instagram chat. Today's topic is IVF, in vitro fertilization. When is it right for me? And this is always an interesting question that many of our patients have. IVF is always on the news and sitcoms, discussed all the time, brought up by your physicians. So let's just start off by just refreshing our memories. What is IVF? And then we'll get into how do you determine if this is the best approach. IVF stands for in vitro fertilization. First baby born from IVF was in 1978. So this technology has kind of grown up as I've grown up, basically. And over the last 30 years, 40 years almost, 40 years, this has changed the way we practice medicine, and most of the giant strides in fertility treatment have come in the IVF arena. IVF was originally devised as a means of helping people get pregnant who had tubal disease, the fallopian tubes which connect the uterus to the area where the eggs are by the ovaries. If they were damaged, if they were blocked, if there was severe scar tissue, if there was lots of endometriosis, patients weren't able to get pregnant easily. And as we have known for many years, doing repeat surgeries on patients, surgeries when there's severe disease present tend not to work well in the first place, and repeat surgeries after prior attempts have not resulted in a pregnancy work less and less and less. So in vitro fertilization was a great advent to help patients with tubal disease. And what it does is it takes the eggs from the woman, fertilizes them in the dish with partner's sperm, creates embryos, and then transfers the embryos back into the uterus. And to give you an idea of how things have changed in this period of 40 years, the initial IVF pregnancy occurred after about 110 to 120 attempts at getting it to work. It was very unsuccessful. People had no experience. They were kind of inventing the process as they went along. And nowadays, if you put a normal embryo into a normal uterus, we'll have 50 to 60% success rate. So this is a tremendous advance over time, resulting from the way it's done, the mechanics of it, the availability of instrumentation, the advances in culture media, embryo testing. Just on every facet of the process has just exploded in its scientific knowledge and our ability to apply that to help people get pregnant. So initially when IVF started, the thought was if the tubes aren't working or if there was severe anatomic disease in the female, how do we get these patients pregnant? The obvious thing was get the eggs out, fertilize them in a dish, and put the embryos back in. The next big trend was treating men who were not able to produce good quality sperm, infertile couples, where the cause, instead of it being the tubes on the women's side, was that the sperm wouldn't work to fertilize eggs. And men with very low sperm counts, where they would have a very difficult time fertilizing eggs in a natural environment, if you put the sperm together with eggs in a dish, a higher percentage of them would fertilize. And then once the technology of intracytoplasmic sperm injection was developed, where you could take a single sperm and inject it into a single egg and cause fertilization to occur, that was the big bonanza in treating male factor infertility, in that it really didn't matter how low the sperm counts were. As long as you had viable motile sperm present, you can use those to fertilize eggs. And whereas, with insemination methodologies, you'd like to have 10 million or at least 5 million sperm to inseminate with, in IVF, when you can micro-inject eggs, the number of sperm that you need is very low. If you have 10 eggs, you need 10 sperm. So it just was another great advance in the IVF arena. And then over time, it became applied more and more to other causes of infertility. So what about patients who weren't successful being treated with ovulation medications, and those patients that either were not successful with injectable ovulation medications or responded in a manner that was unsafe to get pregnant with injectable medications, now were treated with IVF, and it worked for them as well. And then it became patients that, what if it's unexplained infertility? We just don't know why couples are getting pregnant. And lo and behold, IVF works for that group of patients as well. So IVF becomes very ubiquitous in that it doesn't really matter what the cause of the couple's infertility is. It has an application to help patients get pregnant. So on one hand, IVF as a treatment of infertility is potentially available to every couple that's trying to get pregnant. It's nothing exclusive to a specific subgroup. It's available to anybody who's not getting pregnant. And the only question is, do I need to do IVF? Do I need to do something that is more expensive, that requires more office visits, basically, and is more elaborate than a simple method? So, the most important thing when trying to get pregnant, the first thing the doctors in our practice will do before we treat anybody is to try and figure out from them, from the testing that we do, is what is the cause of the infertility to start with. The key to us answering this question is, when is IVF right for me, or any treatment right for you, is us understanding what the cause of the infertility is. And then we have to balance the cause of the infertility, the likelihood of success in treating it in one method, along with the time frame in which we have to treat somebody. Meaning, if you're 25 years old and you have tubal disease where the tubes are blocked or were ligated from a tubal ligation or were removed because of previous surgery, that's not going to change whether you're 25 or 40 years old. If you don't have tubes that work, they don't have tubes that work, and IVF becomes a much more let's do it now kind of a thing. Similarly, if you have infertility due to severe male factor where sperm counts are extremely low and success rates with inseminations or in combination with fertility drugs are going to result in minimal chances of pregnancy, couple percent at best, then does it really make sense to even try inseminations in that group? And IVF is probably best right out of the box as the first means of treating a couple. And then you have a lot of patients that don't fall into those two extremes. And I think most of our patients probably fall in the middle zone somewhere, where if we are trying to get them pregnant, we try ovulation induction with insemination first, and if that doesn't work, then move on to IVF. So when we're assessing couples, particularly for IVF, we need to make sure that they have a normal uterus, that the uterine cavity is normal, so if an embryo is going to implant, it can work. This is important whether you're trying on your own or you're trying with IVF. It's important to know the cavity of the uterus is okay. We want to make sure that there are no dilated tubes, so-called hydrosalpinx, present, because if that's present, having the embryo stick is much more complicated. Success rates go down. So we want to make sure that there's nothing obviously present that's going to prevent an embryo from sticking. Similarly, you want to make sure there aren't any fibroids that are impinging the inside of the cavity, or any scar tissue that might be hiding in the uterus, or any polyps that are in the uterus. We need to know what the male's sperm is like, and we need to know the ovarian reserve to make sure that the uterus is normal, the sperm is adequate, and ovarian reserve is good, so that when we stimulate a patient with fertility drugs, we know that they're going to respond successfully. So the initial thing when we're looking at patients for IVF, they need a basic fertility evaluation. Most of the time we treat people in a stepwise manner, less aggressive things first. IVF isn't necessarily more aggressive, but most people think of it that way. And then it's a matter of how do we put all this information together. And that's really a combination of looking at the science part of it, the academics of it, what makes sense from a medical standpoint, and then how does that fit into what you're trying to achieve as a couple. If we're dealing with someone who has diminished ovarian reserve, and that's basically where the ovary has less good quality eggs in it, and this is assessed either by usually a combination of things. One is age, two is AMH level or anti-Müllerian hormone value that gives us some sense of where we are. Third is antral follicle count on the second or third day of the cycle. And fourth is FSH and estradiol levels. And one of the important factors in deciding should we do IVF sooner rather than later is what's the long-term goal. If we have a patient who has diminished ovarian reserve, we don't like to waste a lot of time doing things that aren't going to necessarily be as successful, because we're trying to capitalize on the ability of that ovary to respond to the medications. We know over time ovarian reserve gets lower and lower and lower. And there's probably no difference in any couple between now and 2 or 3 months from now in doing a procedure. If your ovarian reserve is so bad that 2 months is going to matter, then in reality, at that point, we're already too far gone that it's going to make a difference anyhow. So if ovarian reserve is limited, particularly in couples who want to have more than one child, the major advantage of IVF that we have potentially is the ability to create multiple embryos. And by getting multiple eggs, by stimulating the ovary with fertility drugs, fertilizing those eggs and having multiple embryos, hopefully at the end of the day, if we biopsy them and they're normal genetically, we have multiple embryos available for transfer, which gives us a better chance of getting somebody pregnant, although we try and do one at a time in a cycle. But if not pregnant with one, we have another embryo to work with. And more importantly, if we have multiple embryos and you desire more than one child, if we get you pregnant now and you have extra embryos available, you've preserved your fertility for the future down the road. So, the issue of when you transfer the embryos, or should I batch embryos and get more embryos before doing an embryo transfer, are issues that, again, get discussed with your physician when planning your cycle. And, the long-term goal is of how many embryos do I have, what's my ovarian reserve, what's my age, what are my goals. All these things go into the equation of should I transfer what I have now? Do I want to batch them and keep some for later on? So if we look at patients in general, if we're not dealing with anatomic disease or a severe male factor, we'll go stepwise, and we we'll try inseminations first with a fertility drug in most cases. If there's severe anatomic disease or there's severe male factor, then we really push for IVF as a first step, because the success rates are just so much higher. Similarly, if we're dealing with a little bit of this and a little bit of that, we have multifactorial infertility. IVF will take care of everything, because what you're doing is taking the eggs out of the ovary, making sure we've got the best batch of eggs that we can get on a single cycle. If we get 10 eggs on a cycle, that's 10 months of ovulation doing nothing. So we get a whole year's worth of opportunity in that one cycle almost. And then, we can fertilize those eggs in a dish. So the idea is, when you're doing IVF, is you're creating multiple eggs. You're getting as many good quality eggs as you can. You're bypassing the issue of, does the egg ovulate? Does the tube pick up the egg? Does the sperm find the egg and fertilize the egg? And does the tube transport it to the uterus? And does it implant? All those things are bypassed. So when you do IVF, you get the eggs out, you fertilize them in the dish, you let the embryos grow, At that point, you have the option of doing embryo biopsy for genetic competency to make sure that they're normal genetically, and then you're transferring them back into the uterus. And they can be transferred either fresh if you don't biopsy them, or in a frozen cycle if you do biopsy them. But all those other questions of did I ovulate, did I fertilize, did the tube work, are all bypassed, and the only question at that point is, does my embryo implant or doesn't implant? So the big advantage is to bypass it and have the embryos put back in, and it cuts to the chase. It really doesn't matter what the cause of the infertility is. It allows us to maximize the chance of getting an embryo to stick in the uterus in a given cycle. And the pregnancy outcome is going to reflect that. Now, if you look at pregnancy outcomes, fresh versus frozen cycles, in general, we get better success with frozen cycles. The reason for that is twofold nowadays. One, on a frozen cycle, the endometrium has usually we use a programmed cycle, so we know exactly when to put it back in, but the endometrium is exposed to more normal levels of hormone than in a freshly stimulated cycle. If you have an aggressive response to stimulation, which is good because you make a lot of eggs, on a positive note you make a lot of eggs, but on a negative note the hormones are very high, and that can mess up the endometrium, which has to undergo hormonal changes in response to these changes in your physiology to allow an embryo to implant. And the second reason is the idea that the embryos are biopsied, in that no matter how old somebody is and whether an embryo is formed naturally in your body or it's formed in a dish in a laboratory, a certain percentage of embryos are not going to be normal genetically. And as a result of that, an abnormal embryo, if it's present, is either not going to stick and you get your period. If we do IVF with an abnormal embryo, odds are it's just not going to work. You get a negative pregnancy test. If it does stick, there's a much higher risk of miscarriage, and rarely will an abnormal embryo result in an abnormal baby, and that's why it's so important to do genetic testing if you're pregnant and you haven't done an embryo biopsy. It's also helpful just to confirm that the biopsy was correct and it's got 98% accuracy. So when is IVF a good choice for me? Certainly if there is tubal disease, it's a good choice right off the bat, and it certainly is much more effective than doing tubal reparative surgery. It's in patients who've had a tubal ligation, one can reverse the tubes, but it means having a microsurgery to put them back together, whether it's done with an incision or with laparoscopy, a waiting period of time for it to heal, a chance to see if you're going to get pregnant, an increased risk of tubal pregnancy. It's just better to bypass the tubes totally and do IVF. If there's a blockage in the tube at the end of the tube where the tube is swollen up like a big sausage, then it's important to remove that tube prior to doing IVF, otherwise it will have a negative impact on the implantation of an embryo. But assuming the tubes just aren't working, they're not dilated, you don't need any surgery, IVF's a great approach because it bypasses the problem. Severe male factor bypasses the problem. Have not gotten pregnant with other methods bypasses the problem. Patients who are in their late 30s or beyond, or anybody who has evidence of diminished ovarian reserve, as assessed by your AMH level or previous response to medication, should at least consider doing IVF more aggressively sooner rather than later to try and maximize their fertility potential earlier on. And when you do that, certainly consideration for batching of embryos if you're making a limited number of them. If you want more than one child, is something to discuss with myself or your physician who's taking care of you. And in patients who have been in other treatments and it hasn't worked, if you've been on ovulatory drugs because you don't ovulate properly, you need to have at least 6 cycles where you ovulated normally and nothing's happened before saying it's not working, because the pregnancy rate is no different in a natural cycle if you were ovulating normally versus a cycle in a patient who did not ovulate, that we now restore ovulation. So, you don't want to jump into IVF if you don't ovulate and you just need some ovulatory drugs, and usually if you respond to oral medications, that's adequate. There's some patients that won't respond to oral medications, and when you give them injectable medications, instead of producing 2 or 3 eggs, make 15 or 20, and then the only option we have to safely get them pregnant is IVF. In women who fall into this category with PCOS, for instance, the success rates with IVF are pretty good. Often we'll get more eggs than in patients without PCOS, but a lot of times a higher percentage of the eggs we get are not good quality eggs. So at the end of the day, we'll have more eggs, a lower percentage of mature eggs usually, but when you fertilize them and you get embryos, particularly if you biopsy them and they're euploid embryos, if you do pre-implantation genetic screening or testing for aneuploidy on them, once you have a normal embryo, you have a normal embryo. And PCOS usually will not affect the implantation of a normal embryo unless there's some adverse effect on the lining of the uterus. If you have a good lining in response to hormone replacement, then usually we'll get good implantation rates in that group of patients. And in general with IVF, if you have a normal embryo and you put it into a relatively normal uterus, pregnancy rates with a single embryo transfer are going to be 50 to 60%, with about a 10% miscarriage rate. And that doesn't matter whether that embryo came from somebody with endometriosis, somebody with PCOS, somebody with who's 42 or 44 rather than 23 or 24. The big difference is in the number of embryos that we get that are going to be normal and competent genetically will go down as you get older. And even if you make a lot of eggs, in general, patients who, as you age, make less eggs, and when you fertilize them, you have a normal egg and a normal sperm, but when you make an embryo, a higher percentage of those become aneuploid or not normal, and they won't stick. This question asked, can you just remove eggs once even if you want many children? The answer to that is yes. It depends how you respond. And this is, the fact is going to, the bottom line at the end of the day is how many normal embryos do we have? And if you look at the fact that not every egg that you produce in response to the fertility drug is a mature, good quality egg, and normally not every egg that's good quality is going to fertilize, and not every embryo that forms initially is going to develop for 5 days, you realize you need more eggs to start with to get more embryos down the line. And then if you throw in the factor that age affects aneuploidy, meaning the older somebody is, the higher percentage of embryos are not normal. So if you take someone who's 30 or 32 years old, you would expect 70% of patients to have, 70% of embryos, if embryos that form, to be normal. If you take somebody who's 41 years old, it's going to be the opposite. 70% of embryos are going to be abnormal, and only 30% are normal. So if you couple that with the fact that patients who have less ovarian reserve who are older make less eggs, you can have less normal embryos. So if you're 23 and we're doing IVF for whatever reason, at the end of the day, we may have many embryos, and if you have 5 or 6 normal embryos at the end of the day, that's certainly enough. You would expect, to have a couple children from that. If you're, 38 or 39 and you have the same number of eggs, we might have less normal embryos to work with. So that has to be individualized to an individual patient, basically. The key is that, you've been counseled properly, that your doctors explain the potential of expected outcome so you know what to expect, and has looked at other alternatives. But, if you look at what's my best way to get pregnant, IVF always offers the highest chance of success no matter what direction we choose, basically. And but it doesn't always have to be the first approach. And because of that, we'll usually go stepwise. We'll go through the options. We'll talk about IVF as an alternative and what's the benefits. The issue is, what's the downside of IVF? It's more expensive, no question about that. You have to look at it as what you're using for your cost and your outcome. And if we're doing something that costs less but works 8% of the time versus something that costs more that works 50% of the time, obviously the cost differential isn't as much. So you've got to look at not just the cost of the procedure, but what the outcome for that procedure is going to be. So then you can decide if this makes sense to do right off, because if something costs more but is much, much more effective, it actually costs less if you use the denominator as being a healthy baby being born. So it is important to look at all those factors, basically. Okay, a couple of questions have been asked. 36 can have a low ovarian reserve, prescribed Avigil shots. I did only 2 times. It didn't work for me. Avigil is not going to affect your ovarian reserve. It's not going to create a better egg, basically. Avigil just helps time when you're going to ovulate. It simulates the LH surge and it makes it easier for us to time inseminations. We use it a lot when we use fertility drugs. On a natural cycle, it's really not going to do a whole lot. So it's not something that we usually would recommend. Other downsides of IVF, it requires some injections. You got to take fertility drugs. They're given subcutaneously for 10 days in the cycle. And then when we put the embryos back, you're on hormone replacement. But it works really well. So that's the incentive of putting up with the fact that it's a little more time consuming from the patient standpoint. And if you're dealing with a technology that has a 50 to 60% success rate, there's nothing else we have that can mimic that. Question of 3 failed embryo transfers in the past. What can be done to maximize the chance of implantation? We're going to actually talk about that at next week's chat, is what to do when implantation fails. But just to give a little preview, the question is to make sure that we haven't missed something. On the embryo standpoint, if you've not been doing embryo biopsy would be helpful to make sure we're putting normal embryos back into the uterus, particularly in patients who are older, where there's a higher percentage of abnormal embryos. It's extremely important to know we're putting normal embryos in, because that could be the reason they're not sticking. If we're putting normal embryos in and they're not sticking, the question is to make sure the uterus is normal. You can look at that by ultrasound, by hysteroscopy, and then lastly, to make sure it's how the embryo transfers have been timed. Has it been the right hormonal environment? Other factors such as immunologic factors, or such as natural killer cells or antiphospholipid antibodies that may be preventing embryos from implanting. And lastly, the question is, does the endometrial lining in your individual case respond in an atypical fashion? Is there a need for what's called endometrial receptivity assay testing that may or may not change how we transfer the embryo? So all those things can be discussed with your physician, and we'll talk about them all a little more next week. Low ovarian reserve. Ovidrel alone won't fix that. You need to use fertility drugs, and certainly IVF becomes an option with low ovarian reserve at all to try and capture as much of the fertility potential as you can. Question, can you correct sperm morphology? Not real well. You can use some vitamin therapy, multivitamins, particularly ones that have carnitine and other antioxidants in it, may be helpful. Over the counter for men, Fertile Blend for men works fine, Fertile One male fertility vitamins work fine. Sometimes there'll be improvements, sometimes not. The problem with morphology is that you can have men that have very low morphology and fertilize fine, and other men that have very good morphology and don't fertilize as well. So it gives us some idea. Obviously, if it's very low, we worry more about it. IUI, if the problem is the shape of the sperm, and the sperm aren't fertilizing eggs because they're shaped badly so they don't get up enough velocity in their motion to be able to penetrate the egg, doing insemination is not going to, it'll help a little bit to get more of the more normal sperm higher up, but the sperm that are abnormal are still abnormal. The only way we're going to be able to fix that is with IVF, because you can micro-inject the egg with a single sperm, and there's nothing wrong with the DNA in these sperm. It's just the fact that they're shaped badly so they don't fertilize eggs as well on their own. Success rate for women over 40 is going to depend on the quality of the eggs and the embryo. In general, if you take women, let's say 41 and 42 years old, as a group, and you do an IVF cycle, and you go, if we put back an embryo in that cycle, what kind of outcome are we going to get? You're only going to get 20 to 30% pregnancy rate at best in that group of patients as a whole. Now, if you do embryo biopsy on those patients where you have embryos and you test them for aneuploidy, and you put back one normal embryo, you're going to have a 50 to 60% success rate. The biopsy doesn't give you the highest success rate. The biopsy lets you select the normal embryo, and by putting back a normal embryo, you get a higher success rate. So the reason those two numbers vary by almost twice is that if you don't do the biopsy, if 2/3 of the embryos are not normal, a lot of times you're not going to have a normal embryo to put back. Whereas if you pre-select the patients who have a normal embryo, then the success rate goes up. The major difference between women age 40 and women age 30 is 95% of women age 30, if we put on low doses of medication, going to respond by making 10 to 20 eggs. In women age 40, most of them are not going to do that. Some of them might, but most women will produce less number of eggs, and a higher percentage of the embryos are abnormal. So in general, it's harder to get women pregnant who are older or who have diminished ovarian reserve. In general, if you make a good embryo, we have a good chance of getting you pregnant. But as a group, women age 40 are a lot harder to get pregnant. And when you don't produce normal embryos, or you're over 43, consideration of a donor egg certainly becomes an issue. Just going through other questions here. Can I skip IUI and go direct to IVF? Absolutely. There is no problem going direct to IVF, and we can do that at any time. And a lot of patients prefer this because if you, for instance, if you're treating somebody with a mild male factor, meaning that instead of 15 million sperm with 40% motility, there's 8 million sperm. So we have half normal sperm. Success rates with insemination with Clomid are likely to be maybe 5% in a cycle. We do IVF, we're going to be 50 to 60%. So it's a matter of, we can get 10 times the success rate, and it's not necessarily 10 times the cost. So it certainly becomes an added advantage of it. Type 1 diabetes is not a problem for IUI or IVF, just you want to make sure your blood sugars are in reasonable control before getting pregnant, basically. IVF costs can vary depending on what we're doing. Are we just stimulating you, getting eggs, fertilizing them, putting embryos back without biopsying them in a fresh cycle? Are we freezing extra embryos? Are we biopsying them and doing genetic testing, storing the embryos, and then putting them back on a frozen embryo transfer cycle? So, success cost of IVF can vary anywhere from $12,000 to $20,000 plus the cost of medications in a cycle, depending on what's being done. We have a very nice treatment option for couples called the Fertility Assurance Package that basically says if we stimulate you and you do embryo biopsy and you don't have any normal embryos, we stimulate you again. If you have normal embryos, we put them back one at a time per cycle. And if you're not pregnant, the only requirement before having another fresh stimulation to get more eggs is that you've used all your normal acceptable embryos to transfer, and that's a set price. It includes up to 2 fresh cycles and all the frozen cycles till you either run out of normal embryos or you have an ongoing pregnancy. So that's a very good option for any of our patients who are doing IVF, and we can talk to you individually about those prices in our financial department. I guess Rosie wanted to be live in the video. I'll put you in here, Rosie. Let's see if it works. We'll go live. Rosie, are you there? I don't know if you're still there. Otherwise, we won't. Hi, Rosie. Dr. Jacobs here. What can we do for you? I guess we lost the connection. I'm just going back here, see what else we can ask. Thank you for all the people who typed in thanking us for helping them. It's a great pleasure, and it's certainly can't ask for a better job and more rewarding job than seeing us being successful with you guys. So that's pretty much a summary of what to do with IVF. When is it a right decision for me to make as a patient? It's available, just in summary, it's available to all couples. It's available for any form of infertility. It's not necessarily the first line approach for everybody, but in certain circumstances, particularly in patients with multifactorial infertility, in patients with tubal disease, patients with severe male factor, and in patients where time becomes important, it becomes an important aspect of treatment. And certainly for fertility preservation, whether it's batching embryos for the future to have more kids before putting fresh embryos back, or just preserving fertility because now's not the right time, but I'm getting older and I want to have some embryos for down the road for when we're ready to have another child or a first child. So please, always ask us questions. We're here to educate you and tell you what makes sense, what doesn't make sense, what gives you better results, and why. And sometimes a lot of patients are worried about IVF because it sounds complicated. It's a little more involved and more expensive. But as I've mentioned earlier, if the goal is to have a baby, often it's not the most expensive way, and a lot of times it ends up being less expensive than other methods because the success rate is so good. So I look forward to chatting with people individually and seeing them in person. Let your friends know every Monday at 12:30. We try and do a talk on some topic. Next week's will be implantation failure, what to do when normal embryos don't work. and we'll talk more about how we evaluate that and what options are available for patients. And similarly, if you have a particular topic you'd like us to address, just please send it along and let us know, and we'll try and include it in the next few weeks. So everybody have a good day and stay safe, and we're always available on Zoom as well as in person. Take care.